First question is, Professor, in your experience, how do you bring the youth in order to, what step are needed to achieve that they have better access to treatment and care?
So youth is another group that they need to understand about sexual and HIV, in which in Thailand we also have challenges because our education system and our culture not talk openly about sex and also as sexual transmitted disease. So mostly they would be able to find information from internet. Okay, so we use that platform for them to find out about information and also find out about HIV testing. In our hospital, we have called CU Buddy Clinic. So it's a clinic that we open for HIV and sexual health clinic. So adolescents can come in to get tested. And after get tested, we can see whether they need more on the cascade of care or prevention. So in Thailand, we not do as a best practice yet for adolescents because I think there are still many adolescents out there that not able to get access. In Thailand, it's the same as in Philippines. About 50% of new infection occur in 15 to 24. But our government, the government officers or CBO, try to use different strategy to reach out and be able to, for adolescents to access us. I think we say that adolescent is difficult to reach population, right? But adolescents saying that us is different to find, different to find service. So we still need to have using the world of digital health or internet world to be able to access to us.
It's just like the adults are so have difficulty reaching out to adolescents, but actually they're just there. So sometimes as adults, we also have the problems of reaching out to them. So we need to really initiate. So next, Leslie, can you elaborate on your experience in prevention to maternal to child care, and how can you address that, and how would you help the healthcare providers also regarding that?
Thank you, ma'am. So actually, I'm an adult infectious disease by practice, and my experience is that mostly these women will be referred to us by general OB/GYN for co-management. And unfortunately, most often, there would be instances that they would be referred later on in their pregnancy. So it would be up to, we work with the OB/GYNs to catch up on providing ART for these women. And I think it is very important to emphasize that for PMTCT, there is the importance of time. As we have mentioned, identifying women who are living with HIV during their pregnancy, it's important to catch them early so that we can start them on treatment and we can save we can save 2 lives. So we can start the women in treatment and also prevent vertical transmission. So it is very important for healthcare workers to encourage, or to, as Professor Tanya we mentioned earlier, to make testing in women, especially in pregnant women in ANC, universal. And it does not equate to mandatory testing, but it equates to universal opt-out testing. We have to give that opportunity for the women and the baby to, for them to know their status.
And it's their choice, voluntarily.
Yes, ma'am.
So next, I would like to ask Genesis, can you share, coming from the community, what legal doctrines or other regulation would further support providers to uphold the autonomy, consent, and assent of the young and adolescent in accessing HIV-related services, specifically treatment or PrEP in the absence of parental consent? So I think you had a good experience on that. Can you share to us?
I'm pressured with the word good experience. By the way, yeah, I'm Genesis from Community and Family Services International, and we have a small clinic in Pasay City. And in Pasay City, we have also the service delivery network. So we work in close partnership with different facilities in Pasay, and even how you call that, the positive community, and even the city health office. And to answer what legal basis, first is there's this so-called UNCRC, or the UN Convention on the Rights of the Child, wherein they say about the different principles. And just to highlight, we have this the evolving capacity. Second is the best interest of the child, and the prevention and autonomy. So if we are, since Philippines is one of the signatory, Philippines is obliged to abide. And I think those principles explain on why we should provide services for these young people. And just to specify, we use as proxy consent. And who can provide the proxy consent? For now, the Philippines, there's this COMCHA, or the Committee on Children in HIV and AIDS, convened by the Council for the Welfare of Children. Some of here are members. We were able to develop the protocol on the case management provision of children affected of HIV and AIDS. I was smiling with Rob. Actually, there's this pending case management protocol to be developed, but in spite of that, guidelines being not yet available, having the principles, these principles, we can provide the proxy consent. Who can provide? First, you physicians, those who are physicians here, can provide proxy consent. Second, social workers, but I just want to highlight trained social workers. I myself is a social worker. However, if you are not trained social worker, you can be somehow afraid because our license is at stake. So it's important that you understand on what, in Tagalog, ano ba ito pinapasok ko? Why should I sign? So it's important that a social worker should undergo a training for that worker to sign a consent for that children. So I think, did I answer that?
Yes, it's clear from your experience. So I'll move forward so that we can answer the questions on the screen. So Isabel, representing the youth. So as part of the youth, what would motivate you to access the current available services? And what messages would the youth like to give to their primary care providers? Being the youth, so what would you like to give the message?
Hi, for the youth, as with my experience in the community as I work in the Chancel Philippines, the youth would really want to access the services, but the deterrents are the ones that's stopping them from accessing the services. And the deterrents are the stigma and discrimination. And in order for us to dismantle the stigma and discrimination, we must work with the gatekeepers of these messages. And these gatekeepers are the school administrators, the family, and those including students and the youth who are in the alternative learning system or the out-of-school youths. So the messaging would have to be on the social and behavioral communication changes, materials. So if those could be developed and formulated in a way that is grounded with the experience of the community and the youth, then the youth would not have problems in accessing the services. Because one particular example is that a trans individual would want to access testing, but the friends around her are stigmatizing testing, saying that, why would you access that? Are you promiscuous? So in order for us to dismantle that kind of stigma and discrimination, we must work with the gatekeepers, the DOH, the DepEd, and other concerned stakeholders. Thank you.
And not only that, I think it's what Dr. Louie earlier said, that we should know our rights. So that's a way of promoting it also, that you should know your rights, and when you know your rights, then you can ask for what is the things that you need to access in terms of healthcare services. So that question posted on, I think it's for both of you. I think you read it. So can you share what's your
I think the
comment on
question
that?
is about Should we use efavirenz during the first trimester because of the concern of neurotube defect, and then switch after first trimester to TLD? I think the most important thing is to give the same regimen. What is the benefit of TLD? TLD first have more rapid viral reduction. It brings down the viral load much faster than efavirenz. So it's better in viral control. The second one, TLD, if we use in the first trimester, the risk increasing from efavirenz is minimal. And if you concern, in Africa, they recommended to give folic acid. Folic acid is a nutrition supplement that we usually give in the first trimester to promote or to reduce the neurotube defect. So in short, not need to use efavirenz. You go ahead with transition to everyone TLD. Make sure that they have folic acid in the first trimester. And also efavirenz, which make the neuropsychiatric event, is not good for pregnant women. They will afraid, they will concern. So comparing risk and benefit, TLD is better than efavirenz.
Can you comment in your experience the Philippines, Leslie? I think, yeah. Can you comment
So
also in
actually we
addition?
discussed this with the OBGYN because they're mostly the one who see pregnant women first. And so this is a new, relatively new finding. So it is important that in this session, we are able to disseminate that. We should able to access general OB, primary care physicians that dolutegravir-based regimen is safe and it's the preferred regimen for pregnant women, as Professor mentioned, because of the very fast reduction in viral load, which again, we emphasize for pregnant women, we're really short on time. We have to reduce that viral load fast.
Is there any more question that's going to be flashed? So while we're trying to look into, okay. So consent for HIV testing at 15, but access to interventions such as treatment or prevention is a concern for most providers from your practice. How can you handle these cases of minors? Did you not answer it earlier, or would you like to elaborate further? But this is more on PrEP and PEP. So I think in your experience, can you share also something about that?
Yes. We all know in Philippines, we have this, the RA111, 15 years old and above can access testing. And if they are reactive, policy has a gap on how can these young people access, how can they be linked to care. It also requires consent from the parents. Again, why does consent requires, why does the Philippines require? Because of the parental rights. So that's why most of the people, when they encounter children or young people, we are afraid to handle them. Most of the people I encounter, health workers, they rather not to provide services because these are young people. My license is at stake. I could be sued. So it's because of the parental rights. I cannot directly answer. Just want to highlight. Parents, proxy consent abides with the doctrine of the parents patriae doctrine. What is the parents patriae doctrine? Just a simple, no children have no parents. So for those children who cannot have parents, it is the policy of the, it's the responsibility of the state. But the state has no human body. Who could represent the state? We have the SWD. In the hospital, we have social workers. Sorry, I'm very much in my profession, being a social worker. Maybe some of you are social work, or we have social worker here. But the training, we have this training wherein we're able to not just providing consent, but a holistic approach wherein ensuring that these children will not be left alone. And again, abiding with the UNCRC. the different rights, the principle of survival, the principle of life, the principle of development, of course, the health services. Will you not give that right to these children? So, again, if you're looking for a policy, the UNCRC, there's this protocol. There are different policies in the Philippines. I cannot name 7610, different laws. And I cannot discuss many things here, but there's this specific training for that. You can invite us, not only me, Rob is here. That's part of the advocacy of working on children and young people, ensuring that access to services, even the link to care, and even provision of PrEP, that self-testing. There are specific principles that we follow as long as we are ensuring that we are not creating further harm. We have to be careful. That's why I'm advocating involved social workers, because social workers are trained on how to handle children and young people.
May I share about the situation in Thailand? We also in the past facing with the legal consent, but many groups work and frame this in a way that reproductive health, sexual transmitted disease, including HIV, is a child right. Okay, so if they are of age above 13 years old, which is the average age that they are sexual maturity and start to have sexual debut, if the provision of diagnosis, treatment, or prevention is for the benefit, health benefit of that individual, we can do it, because it's the child right to access to sexual and reproductive health services. However, in clinic, we almost always tell them that from benefit of yourself, we believe that you have adult who you trust being involved in this process, help you. For example, if you want some advice, if you want some support for travel to the clinics, or if something happened, our experience being better if you have adult involved in this process. But it is not mandatory that you have adult or parent present today before you can get access, because it's your right to get access. And we will document that. We will already inform them and then help them to start the process. And usually within the first 6 months, they will have adult that they are careful to be involved. And I think it might not be parent, because they have sometimes have conflict between them. They have stigma or have some issues that the right person might not be biological parents. Sometimes it can be like auntie or someone, but you have engaged for the benefit of children or adolescents to have adults involved in the care for the benefit of them.
So with a particular experience again in the community, when one of our project officer in the organization was trying to provide a HIV testing service to an adolescent age 15, the response of the adolescent was, tatanong ko muna yung tatay ko, or I'll ask my father first. So at that moment, the provider already was scared to provide the service because something might happen, and their outreach is being done in the community. They don't have any protection and stuff like that. So that is where the IEC material should be tailored on, and it should reinforce that the right to health, the right to education must be reinforced in this messaging. And again, I'd like to reiterate that this messaging doesn't need to be impounded on the adolescent and the youth, but more on the gatekeepers, the parents at the local level, along with providing trainings to our healthcare providers. Because the healthcare providers, once trained, they are very willing to provide services. And as long as these trainings are accredited, or acknowledged by the NGAs in the Philippines, then we could have a sustainable response towards ending the epidemic.
Yeah, so speaking from the healthcare provider side, I do have to agree that with Genesis, and that indeed we outside of the HIV community, many healthcare workers are afraid to provide PrEP, and mostly what we see in our clinics are those who were victims of abuse, so we give them PEP. But other than that, they don't really actively go to our clinics to ask for your PrEP, to ask about sexual health. So I think that's one also of the focus that we need to do, that again, to provide a venue for our youth, that they will not be afraid, and to prepare them that when they go to these facilities, the staff there are ready to provide, again, stigma and discrimination-free services. Because we only see them already if they have symptoms, already if they have STIs, or they have symptoms related to AIDS. And I think that's already too late. We have to address it earlier, and we have to ensure that outside of our community, general practitioners, general internists, general pediatricians, they're also equipped to handle the demands of the youth.
Yes, I just want to, if you want a direct answer, how do we handle these cases for minors not willing to disclose to parents? At first, of course, they do not want to disclose, and we do not disclose to the parents. If that's the request of the child or the client, we do not disclose. But as a social worker, I explore many things because I'm looking for eventually that this young person will have a treatment partner, a support system. If still there's a possibility that the family could provide the support system, why not? But if there are other reasons, I have this case, a 17-year-old, and eventually he's now 21 years old, I think 22, and his parent until now doesn't know that he is an HIV positive. And that's his choice. We respect that. Again, abiding with the different principles. That's the abiding with the different, client-centered approach. That's the people, the client knows best for himself. We here as care provider are just facilitating services, but the mere decisions it will come from the client themselves.
So thank you for that. Is there any more question before I'm going to, yes, before I'm going to start opening this to participants? So give me your name and then where you are. I know you're Doc Louis.
Not actually a question, but I just would like to underscore Genesis' point on providing HIV services to minors. She's correct. The Republic Act 11166 is kind of silent on providing services to adolescents and children, okay? Particularly on PrEP, okay? But it did not also say that we're not allowed, okay? As a matter of fact, if you read the what you call definition of terms, there is a minor mature doctrine defined in the early and in the yung first few pages of the implementing rules and regulations. So just to give assurance to our doctors, I mean, Genesis already highlighted the policies, the national, international conventions, and also as doctors, we live on the values now. We should be providing, good to the client, right? So if this is what is needed of the child, then we provide. I think, but I agree, one of the most common fear is, they might be questioned, their license are at stake. But another policy that we can actually cite, that this is new, the mental health law, although this is specific for mental health law, the provisions there are more specific, saying that the minor can actually make decision for themselves, even without parental consent. So, just an update, just for more clarity, we're now revising the IRR of the law. And we had actually an ongoing discussions with CWC. We are developing a more comprehensive case management for HIV services among the young people. Because it's not just proxy consent. I agree with you. You know, it's not just proxy consent, but I think the more important areas are what happens after a social worker provides a proxy consent. Support, behavior change, and psychosocial. So those are more important for the young people. Thanks.
What PrEP can be used for children below 35 kilo? You can still use tenofovir FTC, but you have to titrate dose. For example, if it's like 25 kilo, you can use like 3/4 tablet. Or if you have TAF can be used the same as adult dose at 25 kilogram. So I think you can optimize the dose according to body weight. Can use the same regimen as adult, but optimize dose per body weight.
So next question, can anyone answer that? Genesis, can you comment? Leslie, can you comment? It's more of how are you going to counsel a young child?
So it's important to remember that for pediatric living with HIV, that they start very early, and we have to tailor again how we manage them according to their age and their development. So as I have observed, I've been rotating in Chulalongkorn with Professor Tanyawi, and for pediatric to adolescent, it changes as the pediatric age. So at first, during their earlier years, we engage the caregivers. So we treat them not as an individual patient, but as the entire family. So we engage the caregiver. It's important to that the whole family understand. And then moving on, as they gain more, as they develop, they have the mental capacity and emotional capacity to understand. And we transition them to care, and making sure that they're part of the decision making for their health. So it's a stage-by-stage process. And as healthcare workers, it is our job or our role to guide them through that stage.
Okay, I can add, in child protection, we use the MDT, or the multidisciplinary team approach, wherein different disciplines are being involved. So if there's this case, in Pasay, we have this, the SDN, Service Delivery Network. So CFSI, the peer educator, and any agencies involved with the case of the child, discussing the treatment is through MDT, multidisciplinary. So everyone is involved. And everyone is, have this, ang tawag doon? May liable, lahat kami, responsibility and accountable. Yeah, that's the term. And the child feels important, even without the parents. I think we have no loss to follow-up case because of that.
I would like to address this as a perspective of pediatrician. I think this question not come up in a kid's mind.
Yes.
You need to recall back when you were 10, 11, teenager. You don't think ahead like lifelong. You didn't have that in your mind, right? So the mind of children is like empowered that they have positive experience. So what we did in the clinic is that when they come in, we just give toys, we just give praise that you are doing a very good job, your blood level is very good. So when they're growing up, they can handle, because I did a great job all the way long. My doctor saying that I can manage. They don't know what, but I can manage. That's the mindset we have to give to children living with HIV. And then when they're old enough to understand the whole story or understand or planning the future, they have attitude that whatever I have, I can deal with that. That is the most important thing.
In addition, I would just like to remind everyone, because we're in the Philippines, can you look also in the resources in the Philippines? There's a Crossing Borders that address how to help children, maternal to child transmission, in letting them understand why they are going to take medications. So there's several. It's sponsored by UNICEF. The title is Crossing Borders. So it is the team of San Lazaro Hospital, RITM, and PGH who formulated that manual. So I think you can look into that because it has a lot of information that can help you address the needs of children. Yes, you want to say something?
So on the perspective of the youth, I'd like to share my experience. When I was 17, I was suspecting of HIV. So I was 17 at the time, I was an adolescent, and I was very scared because I don't have any friends that I talk about it, not even my family. So when I was suspecting of HIV, the first thing that I did was search on the internet. And when I look up in the internet, it's like a death sentence. So I was very scared, like, there's no information education materials to help me deal with it. And the only thing that I did was to visit Love Yourself at Anglo. But then when I visited the clinic was very accommodating. It was very confidential. I felt privacy at the most. But then I was alone at the time, so I was very scared that it's like, this is the end of my life. If I tested positive, I don't know what to do. So the messaging is really important. The approach of the counselors is very important and crucial for the accessing of treatment and services of the youth. Because at the time, it was very dark for me that, oh my God, this is the end. So the messaging also has to be changed that HIV is not a death sentence. It can be managed, and there are help and services available to us.
So thank you. Is there any more question? Yes. So I think that's for you, Professor. In relation to prevention, are there specific programs and prevention in Thailand that you can share for us? We can learn also.
So actually, my clinic starting off taking care of children perinatally acquired from families. And then I find that setting is a setting that Genesis mentioned that it's multidisciplinary team. So I think the difference between adult or adolescent and children is that adults can be independent and managed by their own. So children and adolescent, you can have the same service, but you make sure that you have case manager to help them to navigate. You have a social worker to support them when they are need, and also be patient that they have developmental milestone that they need to develop until reach the adult that can be independent. So I think that's the principle. So that can be done either from adult service, that you have that mindset and team to support adolescent. You don't need to create new one. It can be from the pediatrics clinic that have adolescent living with HIV come in and sometimes willing to be peer educator, willing to embrace more people come in and feel comfortable in that clinic. There are different services. Also in CBO, they're also willing to support adolescents. So the short answer is that don't need to create specific new services, but just have accommodating system for adolescent. And if adolescents feel more comfortable to have their own, for example, in our clinic, we assign one afternoon that is specific for adolescent. We not allow children under 10 into that clinic. Don't have other parents, don't have like young children running around. So they feel that they have space, that they can feel that they was the focus of our center, but don't need to create specific, because it's very hard in Thai system. We also don't have adolescent medicine. We have pediatrician and adult. So in the context, there are no existing adolescent to tack on for HIV service, but just use existing service, but differentiated care for adolescent.
So next question. So it's really important that it should be culturally sensitive, age appropriate in terms of intervention. So next question, how can we better integrate sexual health education into existing youth programs to ensure comprehensive and accurate information about HIV. Moms, I think that's for you.
Not just HIVs. I think the comprehensive sexuality education still pending in the school, but there are some initiatives by the UNFPA and other CSOs like CFSI. We go to the community. So CSE is being discussed in the community. And not just HIV, let's make it all everything, like gender-based violence, family planning, because the cases of teenage pregnancy is very high in the Philippines. So I think we have to continually discuss age-appropriate, even as young as 4 years old, the preventive, protective, anything about how to protect themselves, anything about the different parts of the body. So CSE should be available to all age group as long as it's age appropriate.
So to add to that, having discussed that comprehensive sexuality education is in the role of the Department of Education, the problem is that even when we had the gender responsive policy in DepEd issued in 2017, the implementations are still up to the principals or the schools' decision. So in schools, whenever community tapped in a certain school, these schools would only allow community-based organizations to conduct lectures and discussions, but not provide the services. And in that way, they're gatekeeping those services to them, even if this population is known to be HIV vulnerable, even if these populations are known to engaging in activities. So what we really need is to work with them and work hand in hand with them, and not to let them gatekeep the services. And the problem with public schools is that the population receiving lecture discussions are about 100, and that's not conducive for discussions. It should be small groups so that it can be targeted, so that the youth can ask questions intimately, so that they would feel safe and confident to ask questions.
I have a short answer is that when we talk about sexual health education, it's boring, no? It's like parenting or something. But I remember in Thailand we have a soap opera that the actor have living with HIV, and during that year, many people create conversation about HIV because there are some public figure or some soap opera that is very high rated in the community talk about that. So I think the health education should be space for adolescents to talk about their curiosity or their belief, but not education as a book or curriculum, because it can happen in the different stage of life or different stage for not at the same time. That one might be an addition way of spread the concept of sexual transmission disease prevention or sexual health that can be communicated in an adolescent way. Thank you.
I think it's best best people to answer that questions are the young people themselves. That's why I'm looking at that table, those people there, Rob, Patricia, Allen, I think for many years, since elementary, they're already discussing about HIV, sexual reproductive health. So I think I myself learn from them. So they're the best people.
Would you like to comment on that
Please.
table? Can you come up to some stage and comment? We have enough time, 15 minutes.
Sorry,
So, based from experience, sit down over there. Rob, here. Sit down. Join us.
Yeah,
Genesis volunteer you, so.
yeah, voluntold actually. Just to give context, I'm speaking not on behalf of the young people, but more likely on part of the adult. In our educational institution, there actually a decade wherein talking about sex, sexuality, and gender in school is a taboo topic. But there is major challenges beyond that issues wherein we need also to sensitize our adults. This is about time that we need to upscale the literacy of the adults of children's rights. Because if we are pushing for more accessible, available, and appropriate services for children and adolescents, and if we are adult, hamper that just because we see or we view better understanding than the adolescent and children have, then I don't think we will champion young people and adolescent in all aspects. Maybe it is inside the school, maybe it's in outside of their house. But the bottom line of this topic when it comes to health education, specifically for young people, we need to upscale everyone's literacy for children's rights. We need to see and we need to refract our lens on children's, because as we move forward and providing services for them without understanding their needs, without understanding the best interest for them, then we do not champion our children and adolescents.
Rob, thank you for that. I will just make a comment. Remember, either most of us are not, we have nephews, nieces. So we need to look into the fact that parents, sex education should start at home. And it would not be even to start about sex. It should also start from hygiene. And then built on that, I've been also doing this when we conduct training. Start with hygiene, respect the body, which would start on not what is good touch and bad touch. Because at the end of the day, if you start what is important with children as young as 5 years old, they started to explore their body, and then you start with hygiene, taking a bath and all those stuff. Then we would really gradually also teach them about sex education and not just burden the DepEd. So sa bahay mag-uumpisa, hindi lang sa school. Because if parents will have the time to talk about it with children, then we will be able to see also that sex education is just not dependent in the school. So I hope I able to answer that, Rob. And I think you're doing that.
I just want to comment on the previous discussion about scaling up innovations on HIV. On scaling up innovations on HIV, we need also to scale up representation. Because at the end of the day, these innovations is for the end users. And for those end users, we need also to solicit and consult them. Is this innovations best for them? At the same time, I'd like also to comment on safe space for children and adolescents, because like what I've mentioned earlier, if we do not understand their needs and where coming from as adolescent, we need also to clarify our values. We are here in the program for more than 5 to 10 years, providing services, providing commodities. I would like to comment in providing commodities such as condoms, lubes, and PrEP. I mean, I'm also on prevention, but checking on the best interest for my client, for the children, we need also to check and to step back where this decision coming from. That's all.
So with that, before we proceed to the next question, I'd like to reinforce it is the time now that we pass the SOGI Equality Bill. So I advocate for that bill for everyone in this room to tell your friends, tell your peers, tell everyone, and help us to advocate for this bill, because this would be our pathway towards what we're talking about, to sensitize people about SOGI, to make it more implored in the society. So that's what we need as a boost start towards an inclusive society where no one is left behind.
Thank you. Professor, I think that's your question.
So the question is that Thailand somehow managed HIV epidemic curve down the number of cases. What what do you think that Philippines can replicate? The first answer is that Philippines is lucky, more lucky than Thailand in terms of children. Because in Thailand, at that time, when there are like peak of transmission or epidemic back in 1990, it's occur in also heterosexual man. So woman, wife, it's have a peak at the same time. So in Thailand, it's more than 30,000 baby, 30,000 children living with HIV. But I think Philippines, it's still in the window of opportunity that you still have a low prevalence. So low prevalence is a privilege. It's not a barrier for screen and prevent baby. I think you will be more like Malaysia, that is with a very low prevalence. You screen and you block transmission. If you put your resources on vertical transmission prevention, you not need to deal with pediatric HIV, that Thailand don't have that opportunity and have to deal with 30,000 children living with HIV and deal with the psychosocial disclosure, transition, many things. You don't need to go the same way as Thailand did. You should go the same way as Malaysia did. I think Iskandar, you are Malaysia, you should represent that. How lucky that their action at the right timing before all of the hurdle we have to go through. Iskandar, it's Malaysia, you should share something.
Yeah, no, thank you very much. I won't accept credit for it, but I think Malaysia has been quite exemplary from that perspective, in the sense that it had low prevalence throughout and a very highly effective opt-out testing for mothers who are pregnant, and very, very high uptake of that. So very few mothers actually do not take that up. So I think that's one of the key successes of opt-out testing in any HIV testing program that we're introducing. And maybe just a note on that, because it was so successful in Malaysia in terms of preventing mother-to-child transmission, we really should use that approach of opt-out testing maybe in other areas, to scale up HIV testing. So for example, the UK has recently a very successful opt-out testing by introduction into emergency departments. I know I'm going off tangent, but just one way of thinking about that. Thank you.
Thank you for that. Thank you for sharing.